Hi, today we are going to talk about the umbilical cord prolapse, the 2026 guidelines. Umbilical cord prolapse, the 2026 guidelines and checklist. So, why this matters? 0.1 to 0.9% of pregnancies affected 6 to 10% of perinatal mortality and morbidity developed countries. 23 to 27% of perinatal mortality African countries and 18 multiplied higher perimaternal mortality outside the hospitals. So when we defining the emergency, the cord prolapse is the cord descends through cervix beyond the presenting part, occult when the cord descends alongside the presenting part, overt cord descends past the presenting part, and cord presentation, cord loops between the presenting part and membrane before rupture. The clock is running. 57% of prolapses occur within 5 minutes of membrane rupture. Less than 30 minutes recommended to diagnose to delivery interval. 25 minutes is an optimal outcome delivery by this point after sustained bradycardia onset. These are the antenatal risk factors which are very, very important and responsible for the cord prolapse. First is the non-vertex presentation like breech and transverse. If there is a small pregnancy, small gestational age and multiple pregnancies, polyhydramnios, 21-fold increased risk, prematurity, PPROM, the preterm rupture of the membranes, multiparity, 54% higher risk after the third birth and 67% more chances after the fourth birth. Fetal congenital anomalies causing malpresentation. Intrapartum risk factors, that's amniotic, ARM, highest risk intervention, cervical ripening, balloon catheters, then manipulation or the rotation of the fetal head, fetal scalp electrode or IUPC placements, second twin, more common than first twin, and extended cephalic version with ruptured membranes. 62% of the prolapses causes followed by amniotomy versus 37% after the spontaneous rupture. External cephalic version with ruptured membrane chances are 33.3% prolapse rate in one review. So, what should be the prevention checklist? Identify the high risk pregnancy antenatally. Discuss elective admission after 37 plus weeks for the high risk cases. Manage preterm PPROM with non cephalic presentation as inpatient. Avoid amniotomy when presenting part is high, mobile. If required, slow release with the theater on standby. Avoid excessive fetal head evaluation during manipulation or electrode catheter placement and perform high risk intrapartum procedures only with immediate theater access. So, recognizing it and diagnosis, suspect cord prolapse, abnormal fetal heart rate after the membrane rupture, especially with risk factors present, vaginal examination as early as possible with the consent, feel, look, or a soft pulsatile mass in the vagina, look for the cord visible at or beyond the introitus. Cord prolapses must be excluded at very vaginal examination in labor. Occult prolapse is easily missed. Step 1, call for help in the hospital. Emergency bleed now. ISBAR, call senior registrar consultants, alert midwife, neonatologist, theater, continuous fetal heart monitoring, get IV access. The ISBAR is a structured communication framework used for the healthcare to pass a critical clinical information quickly and clearly, especially in emergencies. This I stands for identity, S stands for situation, B stands for background, A stands for the attention, and R for the recommendation. In the community, dial 112 and inform receiving hospital for the transfer. Step 2, relieve the pressure on the cord, manual elevation, two fingers or the hand in the vagina, lifting the presenting part of the cord and maintain under delivery. Positioning, knee to chest or exaggerated Sims left lateral pillow under hip for transfer. Bladder filling, more than 500 ml saline via Foley's if delays expected, usual without theater access. Do not replace the cord. Tocolysis only if fetal heart abnormalities persist. Step 3 is immediately delivery. Assess cervical dilatation, clinical picture. Deliver by the fastest and the safest method, usually cesarean section. Vaginal birth is fully dilated and imminent, 75% in one study, and maintain closed loop communication. Target diagnosis to delivery interval should be under 30 minutes. Out of hospital checklist, arrange immediate transfer, call paramedics every time, position her knee to chest or Sims left lateral tilt. Do not handle or attempt or replace the cord. Consider bladder filling if transfer is delayed. Help her walk to ambulance, then sideline, hip padded. Then pre-alert receiving hospital team before arrival. After the birth, take paired umbilical cord gases, complete incident form plus cord prolapse pro forma, debrief the parents, relatives, and staff separately, offer further debrief at postnatal review, birth reflection service available up to 2 years. Outcome, why every minute counts. This is the largest Irish cohort study of 307 cases, 6.8% perinatal death, 12% nulliparous women, and 4.6% multiparous women. Longer the diagnosis to delivery interval to lower the Apgar scores, meconium aspiration, and SPCRS. Key takeaways. Suspect it at every abnormal FHR after prom. Vaginal examination confirms, don't delay. Call for help is bar every time. Elevate the position, her, don't replace the cord. Deliver within 30 minutes and debrief every time, every case. Thank you so much.